meant to enlighten us on how what we are going to present today can be important, or can be dangerously misused if not taken very well, if not taken the way it should be. So this patient was managed some time back. Have you seen the near miss audit?
Yes, we can see.
So this patient was managed some time back. Like you see, she was 38. She was a gravida 5 para 2 plus 0. By weeks of gestation, by ultrasound scan, she was 38. She didn't know.
Doctor, you've gone mute. Hello, doctor. You've gone mute. We cannot hear you. I think the host should unmute the presenter.
Hello?
Yes.
Hey, there I was not able to unmute some. I don't know. Someone who gave me did not give me authority to unmute.
It is okay. You can continue.
So can we see this?
Yes, we can see, but I think you can make it a slideshow.
Slideshow.
Yes.
Okay. Are we okay
Like
now?
that. Thank you. Yes.
Okay. So initially I was telling you people that this lady was admitted not long ago when this year was beginning, and she was a gravida 5 para 2 plus 0. She was at 38 weeks of gestation by ultrasound scan. She was. We have said that previously she had 2 previous down sections, deliveries. She had 2 abortions, one second trimester, another one first trimester, and she has not had a history of preeclampsia before. At presentation, she had a severe epigastric pain for 1 day, and she had lost fetal movements for 2 days. She also had a serious difficulty in breathing. This is a history of presenting complaint. I don't want to dwell so much on it. What is very clear is that she had no antenatal record available. So from what we discovered because she was an affluent woman, she had a doctor with whom they used to work. So the doctor would request for ultrasound, would request for CBC, but we discovered that that's not antenatal care. Antenatal care is much wider than that. And then, so we discovered that she did not have antenatal care records, and therefore would not have any booking blood pressures. So, but on 3rd March, she had presented at a peripheral clinic with the dizziness, and her BP were measured and they were high. There was around 150 systolic and the 92 diastolic. ALT and AST were normal. CBC was also normal with trace proteins. So no medication were given to her by the attendant doctor at the clinic, and she went home. So on the day of presentation, which was slightly like 3 weeks later, because I think she was admitted on 20th March. That's about, she was examined and she was sick looking with obvious respiratory distress, like we said, and she was moderately pale. Her vitals were these ones, with a pulse rate of 134. Respiratory rate of 30, and SpO2 on room air of 90. Abdomen, she had severe generalized tenderness with the more marked in the epigastrium, with rebound tenderness and guarding. She had features of peritonitis. Fundal length was 36, cephalic longitudinal line, no fetal heart sounds. Bedside scan revealed that she had a non-viable fetus. No, because there were no features of cardiac activity, no visible pool of amniotic fluid at the time. No active bleeding. Noted she had active bleeding sites all over. She was dark skinned, but you could see that she has several areas of bleeding where you would tie for cannulation. That would be blood. So there were visible fluid accumulation posterior to the uterus, paracolic gutters, and posterior to the liver. So it was sort of ascites. The laboratory, she had HB 7.8. She has a platelet count of 71. White blood cell count was normal. Creatinine was very high, notably high. And the liver enzymes were in 10 times the upper limit region. So, pre-referral at the clinic where she came from, they had given her omeprazole, they had given her IV paracetamol and 1 liter and 2 liters of IV fluids. You can imagine that kind of really discovered that there was a serious deficiency in management, as we are going to discover. So the diagnosis at the time, she had HELLP syndrome with an intrauterine fetal death, and because of what we were observing and the gardening and the tenderness, we thought that she had a ruptured liver capsule. So the plan was grouping cross-match coagulation profile, book blood products, magnesium sulfate loading dose, and then an emergency cesarean section. So she was taken for cesarean section, and an intact gravity uterus was found. She delivered a macerated seed birth, 2.7 kilograms, placenta and membranes delivered, uteromedan layers as usual, but she had atony, and was managed by Motive, but then she had a massive hemoperitoneum. And with further exploration, we found that she had a ruptured liver capsule as we had predicted, but it was not actively bleeding. So we mocked excess hemoperitoneum, closed the abdomen layers, but we had to put some Surgisil at the site of the rupture of the liver capsule, repair the skin layers. So she stayed in intensive care, what you would call intensive care, for about 3 days. She was on oxygen. She was fully awake. Blood transfusion. We had blood products, fresh frozen plasma, platelets. Her blood pressure was this, and the patient was given hydrazine and they continued magnesium sulfate. So she stayed at least 3 days. On the 3rd day, the patient was discharged. because her urine output had improved, started improving. She was put on oxygen, and she started on oral antihypertensives and so on the ninth day, that's when she was discharged from hospital, and these were parameters of discharge. HB had improved to 10. The platelet count had improved to 205. Her creatinine had fallen up to 1.8, and she was passing during normal urine output. The AST was still 4 times, but because it was falling,
Doctor, we've lost you. Doctor, we cannot hear you. I think we've lost Doctor. Doctor is requesting to be unmuted. The host should unmute the presenter.